morning, everyone. Welcome to TeleShadowing. We are recording this session and live streaming it to YouTube. We will be having a Q&A session at the end, and you can ask questions in the YouTube Live and Zoom chats, and they will be addressed.
I'm honored to introduce our mentor for today, Dr. Catherine Toomer. Dr. Toomer is a health wellness and weight loss specialist, having founded health wellness and weight loss centers. She has served as a hospice medical director and an urgent care physician, and she is passionate about serving humanity through her Whole You Total Weight Loss program. I would now like to request Dr. Toomer to begin today's session. Thank you.
Okay, I'm going to share my screen first. Okay. Hello, like I said, I'm Dr. Toomer. And so first thing I'm going to talk about is my journey to medicine. A lot of people go into medicine for lots of reasons. Some come up to it later in life. And I decided to become a doctor when my father was diagnosed with colon cancer. I just remember at the time, there was a lot of tension in the house. There was a lot of fear, but I was too young to really understand why. But I knew it had something to do with my father, and I knew it had something to do with illness. And when he came home from the hospital, I sat down with him and I talked and I asked him all sorts of questions and he answered them. And what I got out of that conversation was that he had something that was very serious. He had something that could have killed him, but because his doctors found it early and treated it early, that he has no, he was fine. And so when I heard that, I thought, this is the most important person in my life who's just been saved by doctors. So I'm going to become one. He spoke about his doctors with such admiration. It had such an impact on me. And I was about 8 years old. 2 years after that, my family moved from Michigan to East Africa, and which was a newly independent country. It was in East Africa. So we moved to Kenya, and I saw a lot of diseases that were left untreated, things we wouldn't see here because of vaccinations or because of access to medicine. At least so I thought that it didn't happen here. But anyway, but there I saw, lots of, measles, mumps, treated chicken pox and the complications from that, a lot of river blindness and other parasitic diseases. And so that had an impact on me, on the understanding that there's a disparity in medicine, and a lot of it had to do with access. So I started thinking, if I'm going to be a doctor, I want to be the kind of doctor that helps as many people as possible and tries to provide as wide a variety of people as possible. And so and then also during school, I really loved science. I mean, everything science related, I just had an affinity for it. And so that combination of, having my interest sparked, then seeing diseases up close, and then understanding that I could actually help and have a purpose in this world, and then combined with my science, that kind of kept me driven towards medicine. My educational background, I did my first year of college at the U.S. International University in Nairobi. Oops, let that happen. Okay. My educational background is at International University in Kenya, and I really wanted to stay there. However, because I was a foreigner in Kenya, I couldn't attend the universities that would have allowed me to be a pre-med student there and then go on to med school. So I finished my first year in general studies and then came back to Michigan, which is where I was originally from, and attended Michigan State University and got my first degree in the College of Natural Sciences. And as I was going through, and I found out about a post-baccalaureate program at the med school. My very first choice was Michigan State University Medical School, mainly because I was told that, they not only graduated doctors, but doctors who are also like social workers, and that appealed to me. And so I applied early and actually got accepted before I graduated. And so I finished up my undergraduate program while in the post-bac program. And essentially what it was, it's a program where if you maintain a certain GPA, you're automatically accepted into the med school at the end of it. It's a 1-year program. And during that time, some of the larger, you're taking one med school course a semester while you're taking other undergraduate courses that bolster things later, like um, physiology and biochemistry and histology and all the like. And so when I started med school, I was actually a little bit ahead because I had already taken 4 med school courses, some of the largest med school courses too, like, anatomy and physiology, which is probably the bulk of the first semester of med school, and I had already taken it. So that gave me a lot of time to study my other classes, and really kind of gave me a leg up when starting med school, which is another avenue to med school is a post-bac program, which not everybody understands or has heard of, but there are many schools that have them. And then when I finished medical school, I was actually married by that time. My husband and I met our first day of med school. We were married 2 years later. And so when we went to residency, you go through what's called a match, and you apply to various residency programs, whatever field you want to go into. You interview at those places, and then you rank them. And they also rank who they interview. And what happens is there's this algorithm program that sort of matches people based on their rank and based on how you're ranked. And so my husband and I went through what's called a couples match, and which made it a little more difficult because his program had to rank him, my program had to rank me, and we had to rank them both. Both of us had to rank them. And so it was a little bit up in the air because we had no idea where we were going to fall in our order of preference. And it turns out we were very fortunate. We both matched to our second choice, which was the University of Florida, which if anyone's from this area, from the Southeast, knows that Shands at the University of Florida is one of the largest hospital systems, is one of the most respected hospital systems. So we were very happy at that point. One of the beautiful things about my residency program is that Shands at University of Florida had more than one hospital. And one of those hospitals was exclusively for family medicine residents, which meant that we were unopposed, which meant that everything that happened in the hospital, all the experiences that learning experiences in the hospital, all were given to us because there were no surgery residents to take over the surgeries. There were no pediatric residents to take the pediatric admissions, any infectious disease, just everything that was available we did because we were the only residents there. So it was a wonderful learning experience. So just to reiterate some of the road to family medicine for anyone who's interested in family medicine, I started as a pre-med biological student, biological sciences student, and then I got involved in campus activities. One of the things that I kind of kept an eye on was making sure that I had extracurricular activities that sort of gave me a wide variety of exposure. So things that included student leadership, that included access to faculty, and probably one of the most beneficial extracurricular activities I did was being the student representative on the Dean's Council. And the reason that helped me later is because one of the people that I worked with on the Dean's Council ended up as the admissions director for the med school I wanted to go to. So she already knew me before I even walked through the door. I also got involved. I joined a sorority. I did a lot of community service, but I made sure there was a balance so that those things didn't interfere with my academics, which is very hard to do. But it's a good place to start to learn how to balance life and academics, so that when you get to med school, it's a skill that's really worth having. And then I took my MCAT at the end of my junior year. I took it only once. I I had been advised to take it again. I didn't. My scores were average. They weren't, stellar, mainly because I didn't really study for it. I just sort of took it based on my, um, and so because I didn't really have a whole lot of advice on what to do. And so I took my MCAT. I took it once. I said, well, if they're not good enough to get me into med school, then I'll take it again. But I got accepted, so I didn't bother. And so when I applied to medical school, I was told about the post-bac program. And so I just jumped at it. I didn't really care how I got into med school. I just wanted to get in. So if there was a program that would allow me to automatically get into the med school, I jumped on it. It added an extra year, but I didn't care. I mean, now 25 years later, that extra year means nothing. But I also gave me a chance to apply to the National Health Service Corps for a scholarship. And what the National Health Service Corps is a scholarship that the US government or Health and Human Services provides to people who have dedicated their lives to primary care, which is psychiatry, obstetrics, family medicine, internal medicine, pediatrics, and serving underserved populations. I already knew that I was dedicated to serving the underserved. Disparity in medicine was very important to me, and I wanted to be a part of the solution. So for me, it was a win-win. It was a scholarship that paid all my tuition, gave me a monthly stipend, paid all my living expenses, and all I had to do was work in an underserved area for every year that they paid for my education. I was gonna do that anyway, so it was perfect. My husband, who I hadn't met yet, he happens to be from South Carolina, which the whole state is pretty much underserved medically. And so it served me well. Everywhere I've lived has been considered a medically underserved area. So I could live where I wanted and still, pay back my obligation. And the hope is always that once that obligation is up, that you stay. And that's exactly what I did. Um, while in medical school, there are electives, just like in undergrad, you have a chance to pick certain classes. And what I did was as many rotations in family medicine in different aspects of family medicine as I could. I worked with family medicine doctors in the emergency department. I worked with family medicine physicians who worked in large groups and others who had their own solo practices. And I got to see the different ways that family medicine could be practiced. But even that didn't prepare me for all the other options that were out there. Um, so after that, again, I mentioned I went to the couples match and interviewed at multiple programs and then matched to my second choice. And as they say, the rest is history. So, so what is family medicine? Um, Family medicine in the South, we have this joke, we say it's from the rooter to the tutor, which basically means from the mouth to, um, well, basically the whole body. Let me just put it that way. Um, and also it's from conception to grave. So, anything from pre-conception, helping women get pregnant, or families get pregnant, to taking care of women during pregnancy, to then delivering babies, taking care of that baby from the time they're born, and then all throughout life, even to end of life, like hospice or, geriatrics. And so my approach to family medicine is basically what I learned in medical school and what I've done through residency and have carried with me. And what that is a biopsychosocial approach. And what that is that you use the person's biology, their psychology, and their social interactions and uh, their sociology to help treat the whole person. And so, because when dealing with a person, if you're only focusing on the medical part and you're not paying attention to how it affects their family or how their diagnosis affects them psychologically or understand them psychologically, because that affects compliance in whether people take their medicine, whether they accept their diagnosis, how they behave once they've been diagnosed. It you're only halfway treating. So I had to pay attention to all of it. And I still use that approach even now. But what attracted me to family medicine as opposed to um, the other primary care areas was that family medicine, you can go anywhere and do anything with it. I knew that if I decided to go back to Africa, if I decided to stay in rural South Carolina or anywhere else, the more I knew about all the aspects of medicine, the better. And so if I needed to take care of a pregnant woman, I could. If I needed to deliver a child, I could. If I needed to help, the great grandparent of that child, transition, comfortably, I could. And so I could be a true family medicine from every single person in the family and take care of them. And one of the things I also realized is that, and I found this out later, is that when you are a physician in a community, you get called upon to do a lot of different things. And it also opens the door to a lot of opportunities in your community, doing research, leadership. Often you'll see people in the media are family doctors. It's more common to see other doctors in family medicine, but at the time, other doctors in media, but at the time when I was going through, mostly almost all the doctors, I don't know if any of you are familiar with Dr. Drew, but he was probably the most well-known media physician, and he was a family doctor also. So that just reinforced what I also thought was important. So in practicing family medicine, there's lots of different ways of practicing, but the most common things that we encounter, particularly early on before finding our niche, is wellness and prevention. We're the gatekeepers. We're the ones, when you talk about the Affordable Care Act, a lot of that was on the shoulders of primary care physicians, or especially family physicians. We're the ones who determine where people go, who they get referred to, how they get treated. We do a lot of the diagnosing of, we're often the first person that anyone sees. And so we see a lot of infections. We deal a lot with pain, emotional pain and physical pain, which, mental health, a lot of diabetes and hypertension, a lot of lifestyle related diagnoses, cardiovascular disease, gastrointestinal, skin disease. There's just so much. We also deal with people just having difficulties in life, and we just kind of help. Now they call it life coaching, but we did that all along. We've always helped people kind of navigate their life in order to help them with their health. So I'm just going to talk a little bit about some of the more common things that we deal with in medicine. I would say the one that has the most impact on people and their health is diabetes. And what diabetes is, it's called diabetes mellitus. Now, there are different types, but the most common type that's related to lifestyle is, or related, that we see most commonly is let me back up a little bit. Sorry about that. So diabetes in and of itself is the inability to metabolize carbohydrates. And what carbohydrates are is a complex carbon, hydrogen, and oxygen-based compound that gets broken down so that the body can then utilize its components for energy, mainly either to use right away or for storage. And that compound is glucose. So because glucose is so important in maintaining brain function, in maintaining muscle strength and muscle ability, our body prepares for it right away. As soon as we bite into something that has a carbohydrate in it or starch, our body starts breaking it down with our saliva, with amylase. Then it goes to the stomach, gets broken down by acid a little bit more, then goes into the intestines, and then other enzymes start working on it so that it gets broken down to its smallest components. One of those components is glucose. And when it's broken down to glucose, that glucose sends a message to our pancreas, which is part of our digestive system. And there are cells in our pancreas, beta cells, that produce insulin that allows that glucose to get absorbed and utilized in the body. So you can think of insulin as sort of a key that goes into a lock that opens a door for insulin to get into cells so that it can be, so that glucose can be used, get into the cells so they can be used for whatever process the body needs. And it's very, very, very efficient. However, when it gets disrupted, it can cause all sorts of problems. So diabetes mellitus type 1 is often the type you see in childhood. And what happens is the beta cells in the pancreas do not produce enough insulin. So therefore, there aren't enough keys for the locks, essentially. And so what happens is that blood sugar stays, the glucose stays in the blood rather than going into the cells where it's needed. And I'll talk a little bit later about what problems that causes. But high blood sugar is one of the ways we check for it. You can check for blood sugars. There's lots of different things using glucometers. I'm sure many of you are familiar with. And basically, it's just pricking your finger, checking. Well, now they have them where you can actually do it by a patch with an app. But essentially, you check blood sugar, and it tells you how high it is. And a normal blood sugar is between 70 and 100 when you haven't eaten. And at the highest you want to go is 140 if you have eaten. And so we check for those numbers to see if it's something we need to treat or we need to educate. And but again, type 1 is usually childhood. Usually it's from an immune reaction to killing beta cells, which then does not produce insulin, which means that those keys to getting glucose into the cell have been disrupted or aren't enough of them. Now, the one that we see mostly in family medicine, type 1, we diagnose and then we send them off to specialists usually. However, type 2, we treat. We find it, we treat it, and it's more common in family medicine, and it's very much lifestyle related also. And what this is your body, it produces enough insulin, but the cells that have the lock and key just can't use it. So the key is there, but there are no keyholes to put it in. And that happens over time. It happens for many reasons, but essentially, it usually happens slowly over time in adulthood, and it's related to eating habits, obesity, sometimes genetics, but it's usually a combination of lots of those things. So it's just all these things put together create type 2 diabetes, which is also why it is the easiest to reverse. Type 1 cannot be reversed. Once you have it, it's there. But type 2 can be through lifestyle changes. And usually it's treated with different medications, like many pills that make the cells more sensitive to insulin. So basically, it just creates more keyholes for the key to lock into. However, when it gets to a point where it's very advanced and or left untreated for too long, then we have to produce insulin or give the patient insulin in order for them to then overcome type 2 diabetes. And the reason it's so important to catch diabetes early, to treat it early, is because when uncontrolled, it just causes so many problems. What diabetes does is it hardens blood vessels. The sugar in blood attaches to blood vessels and makes them hard. It makes it harder for blood to get to every part of the body. So as you can imagine, every major organ in the body gets affected. And so it can cause strokes, blindness. It is very common in tooth decay, heart disease. It causes nerve damage like tingling and numbness and kidney failure. But a lot of those things combined also lead to amputations of limbs. It can lead to essentially a slow and very painful and very um, a death that is slow and just and not very pleasant. Um, but again, like I said, when caught early, when caught it can be reversed, and so there really isn't a reason for this to go on. However, when someone is uncontrolled, it's really important to determine why, and that's where biopsychosocial approach comes in. Most people want to feel better. Either they don't know how, they don't have the motivation to, or there may be other reasons like finances for medication. And it's really important in family medicine to figure out the why and not just focus on what's happening, but knowing why it happens and then addressing those whys. The second uh, diagnosis that we deal a lot with, and it's really important to get under control, is for the same reason as diabetes. Hypertension is the pressure of what happens when the heart pumps and when it fills. And each time it pumps and fills, it changes the pressure on the walls of blood vessels throughout the body. And so it's really important to pay attention to anything that affects our blood, our blood vessels, because that's how we get oxygen to every part of our body. And so anything that affects that our blood vessels is important to find and fix. And so the way that blood pressure is checked is with and I'm going to say, I'll take a pause, and it's sphygmomanometer. Now, anyone who's in medicine will tell you they always pause before saying that word, and we generally just say blood pressure cuff because it's just so much easier, and most people don't know what a sphygmomanometer is anyway. So what it is that you put a band around the arm and pump it up with air, and what it does, it cuts off blood flow. And as you release that pressure, the pressure inside the blood vessels will start to push against um, the walls. And during the time that you're releasing, you also listen. And our blood pressure is from the time you first hear the heartbeat against a stethoscope as you're releasing pressure to when that sound goes away. And that is called the systolic, which is the pressure of the heart when it pumps. And the diastolic is when the heart is filling to pump again. And that number is the systolic over the diastolic. And that's the number we look for. And we determine if someone has a hypertension or high blood pressure, and then determine how much of a treatment is necessary or what type of thing needs to happen. And so hypertension is actually called the silent killer. And the reason is most people walking around with high blood pressure don't know it. Even if they have it and it's being treated, you normally can't feel it. You often hear people say, I can tell when my blood pressure is high because I get a headache or I feel a certain way. Well, generally what it is that feeling causes the blood pressure to go up, not the other way around. And so a normal blood pressure is 120/80. High blood pressure is anything over 140/90. And the reason, again, it's so important to get that under control is because pressure against blood vessel walls cause them to get disrupted. They can burst, they can stiffen. And so again, it causes some of the same things that diabetes causes: heart disease, blood vessel hardening, stroke, blindness, kidney failure. And so you can imagine if someone has hypertension and diabetes together, they can end up really sick. And so a lot of our time in primary care in clinical family medicine is to prevent these things. And if we find them, then to reverse them so that a person can have a better quality of life. The other that we deal with quite a bit is mental illness. Depression is probably one of the most common, is probably one of the most overlooked when looking at symptomatology of patients, mainly because depression often manifests as physical ailments. And so it's very easy to focus on the physical findings and on the symptoms rather than the actual person. Um, but it is a persistent feeling of sadness and hopelessness or loss of interest in activities that people once enjoyed. And there's different levels of depression. Sometimes it's brief, sometimes it's prolonged, sometimes it's reactionary, sometimes it is from reactionary to one event, like grief is a form of depression, can create a form of depression, or someone who's dealing with a trauma, a life trauma of some other type. But um, it's usually diagnosed either through screening. There's a screening questionnaire that doctors use to determine if someone is depressed, and their answers are scored, and depending on the number that comes up, will say if they're depressed or not. The actual criteria for depression is using a set of symptoms from the Diagnostic and Statistical Manual of Mental Disorders, what we call the DSM. Now, every few years, the College of Psychiatry puts out a different set of criteria for all different mental illnesses. And as they put them out, the numbers change. So the next one that comes out, right now we use DSM-5, the next one will be DSM-6, and then the next one after that, 7, and so on. Now with depression, there are degrees of depression. Some of them are mild, which is what we call sort of dysthymia. Basically, it's just a generalized low-level sadness. And then there's others that are very severe that can cause some type of hallucination. It can give the impression of someone being schizophrenic when they're actually not. And it's usually reactionary. And again, it's really important that in family medicine, that we recognize what's outside of our scope, what we can treat, and then what we need to refer to a psychiatrist or someone with a little more expertise in that area. But we're often the first to diagnose it, and we're often the first to treat it. And so, and the reason I threw depression in there was just because to kind of underscore that what we deal with isn't just physical ailments, but also psychological as well. And so the criteria for depression is usually like depressed mood for most of the day or nearly every day. Diminished interest or pleasure in all or almost all activities, most of the day or every day. And so if someone, it's a very good question to use, not just within medicine, but in life in general. If you have friends and you start noticing that they used to play an instrument and all of a sudden they stop, or they used to draw or something and they stop. Any hobby, all of a sudden you start noticing, or they stop wanting to be around friends. They stop wanting to go out. It's a good time to start paying attention and to focusing on whether they're depressed or not. And it's so easily treated, and it affects life so greatly that it's always something good to look out for in friends and family, or even in oneself. If you start noticing significant weight loss when not dieting, or weight gain when not trying, increase or decrease in appetite is another sign of depression. Someone who suddenly starts speaking very slowly, starts moving very slowly, suddenly doesn't want to get out of bed. They're physically just tired. Or they just can't sit still and get restless when, ADHD or hyperactivity or attention deficit was not something that was there before, and all of the sudden starts. You start seeing fatigue, a sense of worthlessness, Another sign you'll start noticing, like every time someone says something, it's always in the negative. Oh, I'll never be able to do that, or this is always going to be bad. Um, that can be depression. A lot of times when people say someone's negative, it's actually, yes, they may be, but the negativity is a symptom of something else. Another is people becoming indecisive, not being able to focus, not being able to make decisions, suddenly being extremely insecure, losing all motivation to do anything. And the most severe is when someone has suicidal thoughts. They may not have a plan. And just because someone has suicidal thoughts does not mean they are suicidal. There's a difference. Not everyone who thinks about suicide will actually commit suicide, but asking someone if they are suicidal does not make them suicidal, but it can prevent it. And so these are, so as you can see, there are a lot of criteria that have absolutely nothing to do with often what's misconstrued as depression, like crying all the time, being sad all the time. Often you may see someone who's actually quite cheerful, but they are depressed. But if you start noticing all the other symptoms, there is, depression is underlying, and it's easily treated with medication through counseling. Um, and but if left for too long without being treated or addressed, can get worse. And the reason is that depression causes a chemical change in the body, in the brain, particularly in the areas that regulate emotion. And it's really important to understand how that works, because it changes how it presents, it changes how bad it is, and how to treat it. And so the area of the brain that essentially affects depression is called the limbic system. And there's three parts of that system that are generally related to depression: the amygdala, which regulates emotion; the hippocampus, which is for learning and for habits, that sort of thing; and the thalamus, which basically relays emotional information to the rest of the brain that controls your motor skills. So that's part of the reason why when people are depressed, they sort of shut down. They don't want to move. They want to sleep all the time, because it does affect alertness and your consciousness. Um, but and studies after study shows that when someone is depressed, those areas of the brain can be imaged, and it will show that there are different structures and different functions just from depression. And again, it's hard to tell which comes first, the chicken or the egg, if the brain changes and causes depression, or if the depression causes the brain changes. However, it can be imaged and it can be seen on different types of brain scans. So to talk a little bit about a day in the life of family medicine, like I said, family medicine has a lot of depth, a lot of breadth. Um, and so there really is no one way of being a family medicine doctor. My first um, job in family medicine after residency was at a community health center in rural South Carolina. So when working at a community health center in rural South Carolina, I was one of very few doctors in an area in the county. And so I saw a lot of different people for a lot of different reasons. It was very, very important in that time to really rely heavily on what I call the biopsychosocial system. And mainly because poverty was an issue, illiteracy was an issue, family structure was an issue, um, and access to medicine and medication was an issue. Often I didn't have the ability to refer people who were more complex because they had no way of getting to a specialist. I couldn't prescribe certain medications because their insurance, if they had it, didn't even cover that medication. And so you get really resourceful in how to treat people in a way so that it fits into their economics, it fits into their education level, it fits into all the rest. Um, and so I saw a lot of people with uncontrolled diabetes and hypertension, which meant that their life expectancy dropped dramatically. And so it was my job to essentially, with adults, to kind of keep them alive for the next 5 to 10 years, for children to make sure that I could prevent them from becoming adults with hypertension and diabetes or other disease like thyroid and every disease. I did a lot of gynecology because I was the only person that people had. So I had to do everything. Um, and so I spent a lot of time not just focusing on symptoms, but why they were there. Or if someone was feeling a certain way or not taking their medication, I had to know why. And many times it was financial. Like I said, illiteracy was a reason. People often, medication side effects, they'll stop taking something because it will make them feel a certain way. Um, or they will doctor shop and end up with, different doctors treating the same thing with different medications, and they're not telling one doctor what the other doctor's doing. And then a lot of it is lifestyle. And so unless you focus on the why, the what never changes. And so that's what I did a lot of in community health. During that time, I also became a hospice medical director where I performed home visits. I did examinations. I managed people's symptoms, mainly pain medications. Um, but also, I had to manage family around medication because a bunch of it was, like I said, were controlled pain medicines, a lot of morphine, oxycodone, oxycontin in the house, um, different medications to help people with agitation, like Xanax. But for people who are dying, it's easy to want them to be comfortable. However, there are family members who know that if someone's on hospice, they have those medications in the house. And so it's really important that we pay attention to how much we prescribe, how many pills are in the house, how often it should be taken. And a lot of that time is spent making sure nobody else is taking it. Again, that's the social part of biopsychosocial. And so as a hospice director, I did a lot of end of life care and coordinating. Like I said, family dynamic management, not just about around pain medications and controlled substances, but also guilt. There are many family members who feel guilty when a family member is dying and they show up, and they often cause a lot of problems because the people who've been there all along can sort of get pushed aside. So we have to deal a lot with that around the emotional support. We do a lot of education and managing people's expectations. A lot of times there are different stages of grief, and we often have to manage the miracle expectations of families. But one of the biggest parts of medicine in general, family medicine, but specifically with hospice, is learning how not to be affected by death. You're always affected, but there are ways of managing your emotions so that you don't carry it with you all the time. And it is very hard for doctors to do this, which is partly why depression levels in physicians are often very high. The suicide rate in doctors is 3 times higher than the national average, because it's based on not recognizing how these things affect us. Some people can compartmentalize very well. Other people need counseling. Other people need medication. Whatever it is, though, it does affect us. We're humans. We're not robots. So after 20, 25 years in medicine, I decided to take a bit of a break. And one of the ways that I did this was by working in an urgent care center. Well, I decided to open my own office, but I wanted to do it in a way where I didn't have to borrow a bunch of money, and I didn't want to have to, I wanted to be able to work on my own terms. And so I knew the way to do this was basically working in one place to supply money for the other. And so I started working at an urgent care center. And what an urgent care center is, which are more common now than they were when I was earlier in my career, but essentially they're like the gap between private practice and the emergency department. And so essentially it's just people who have a place to go in to get quick care and leave. There's not a concern about continuity. You don't see the same people over and over again usually. It is shift work, so it's very nice because you know exactly how long you're going to work every day, which in offices, that's not always the case. With uh, home visits, that's not always the case. And so usually what you hope for, what it is for people who have urgent issues that are not emergent. However, those emergencies come through as well. So you do see a lot of heart attacks, or people, you have to determine if they're having a heart attack because a lot of symptoms in medicine mimic one another. So when someone has chest pain, you can't always tell if it's from your heart, if it's from, you know, acid reflux, if it's from, uh, you know, someone having an old chest injury. And so it's kind of like a form of arthritis in their chest bones. And so it's really important to determine what those things are and rather quickly. Um, but again, a lot of parts of medicine in general, and especially there, is to be quick in understanding what it could be and ruling them out. Managing people's emotions. They don't like getting, when you come into an urgent care center, people don't know what's wrong. And when you tell them what is wrong, sometimes they just won't accept it. And so you have to learn how to manage the emotional reactions to whatever it is you tell people. Um, the other is managing treatment expectations. You know, you tell someone I can treat this, but it's going to take 10 days or 20 days before your symptoms are going to go away. Um, and they want it gone now. And there's no way for that to happen. And so often when doctors get blamed for things that are just simply beyond our control, it's just not how the human body works, but people think it's our fault if it doesn't work the way they want. Um, the other is understanding there's a lack of continuity. So if someone is, you know, diabetic, or you diagnose them with diabetes at an urgent care center, you have to make sure they get in with someone who will follow that person all the time, because otherwise they'll fall through the cracks. And so in urgent care situation, much like with all parts of medicine, it's really important to establish rapport. People don't tell you good information. They won't tell you the truth if they don't trust you. So it's really important then to establish a sense of trust so that you can get to the bottom of what's really happening. Um, and so now what I do is I'm a health, wellness, and weight loss coach, counselor, and consultant. And the reason I've done this is because I was getting very, very frustrated with really helping people in clinical medicine. I knew that in order to really get people well, to help them really reverse their disease states, was to spend a lot of time with them, talk to them, get to the, you know, really understand their life fully. And I felt like medicine was going to a model where I felt rushed, and I didn't want to feel rushed. I wanted to truly help people. So I opened a small practice, and what I do now is I essentially hold people's hands and get them from point A to point B in a way more quickly and with far more direction than if they had to do it on their own. And then once they get there, you know, I just kind of give them a plan so that they can maintain it for the rest of their life. And what's wonderful is that because I work for myself, I have complete autonomy. I can control my schedule completely. I don't know if you've heard much about physician burnout, but that prevents my burnout. I love what I do. I can practice the parts of medicine that I enjoy the most. There are lots of aspects of medicine that I don't enjoy, and that's just human nature. Not everybody's going to love everything. But if I control my own practice, I can, you know, pick and choose what I deal with and refer the rest. The other is that I feel that I really can use my training effectively because I can help people become empowered, um, and which is ultimately what you want in medicine in general, is to get people to a point where they feel like they can really take care of themselves. And the other that helped was that I happened to be in a place though that when COVID hit, it was very easy transition for me to go from an office to going online. And because it was just me, um, it was, and I could, and most of what I do is not physical examinations. Most of it is understanding the causes of things, and you don't have to necessarily examine someone in order to do much of that. And the reason why I focused on weight loss mainly is because I started seeing people being taken advantage of using weight loss companies with no medical background, taking advantage of people's uh, desire to lose weight when they weren't at all focusing on why they gained weight in the first place. Weight is a symptom, and unless you focus on the cause of that symptom, it just, it may go away temporarily, but it always comes back. And what that does psychologically to the person that it's happening to, and physically, can damage their health and damage their physical and mental health. And so the reason I focus somewhat on weight loss also is to kind of help those people, get them out of that toxic and weight loss environment so that they can really get healthy. And so that's what I do now. And and so one of the things I always tell people, and this is something that uh, one of the reasons why I also do weight loss is because I improved my own health and wellness by losing a significant amount of weight about 20 years ago when I had a health crisis of my own. And that's what gave me the idea to start this business. And so I always say the most important part of medicine is to practice what you preach. And so what I did is I lost a significant amount of weight. I was an insulin dependent diabetic, which I am not anymore. And I then created a program to help other people do the same thing. So my advice for all of you, one is to take advice from the people who've actually done it. I can't tell you how many times I had people who had never been to med school telling me how to get in. And that happens a lot. Oh, you don't want to become a doctor, you want to do XYZ. Oh, it's so hard. Oh, you won't be able to have a family. Oh, you're going to have this. And none of them are doctors. And it's like, how do you know? And I see a lot of people being talked out of going into medicine by people who've never done it. So my advice is, if you want to learn how to fly a plane, you ask the pilot. You don't ask air hostess. So the same is for medicine. If you want to become a physician, get advice from people who have actually done it. Understand that it's a marathon, not a sprint. It's a slow and steady process, and consistency and stamina wins. There are a lot of people in medicine who are brilliant or who went to med school who were brilliant, but didn't have the stamina to get through the work on a day-to-day basis, or they didn't work daily and they kind of shoved everything into a weekend before exams. That doesn't work for medicine. It's just something you have to do every single day and stay focused. It won't always be perfect, but as long as you're progressing, that's all that matters. And that's my next point. You don't have to be perfect. I can't tell you how many people say, oh, you have to have a 4.0 GPA. Oh, you have to have these extracurriculars. Oh, you have to have done research. You had to have shadowed 5 or 6, 7, 8 doctors. You had to have done all those things. Most of the people I know who get into med school have done none of those things. They don't have a 4.0 GPA. They don't have, extremely high MCAT scores. They don't have any of these experiences. They just have determination, and that's it. And confidence. If you know you want to be a doctor, know why and be able to tell people why. Communication, being able to communicate is probably one of the biggest pluses for getting into med school, because no matter how good you are at something, no matter how well you've done, if you can't relay that to other people in interviews, then, they're not going to believe it if you don't believe it. Surround yourself with supportive people with similar goals. Nothing sabotages someone faster than someone else's insecurities. There are going to be a lot of people trying to um, do little things, and they may not even realize they're doing it, but you say, oh, I want to become a doctor. Are you sure? Really? I had a friend who did XYZ and they went to med school and they hate it. Or I have a friend who did this and, my uncle's a doctor and, they're never home. He had a heart attack when he was 45 because he just worked so hard. Anecdotal stories mean nothing because one of the beautiful things about medicine is that once you have MD or DO behind your name, the world opens up and you have a whole lot of choices and options. So no matter what anyone else did, that doesn't mean you have to do it. No matter what happened to somebody else, doesn't mean that's going to happen to you. And so, or, oh, you're going to have so much debt. I came out of med school with no debt because I had a scholarship. There are ways of getting through med school without owing any money at all. There are also ways of, and then sometimes that debt doesn't really matter. People, you say you're going to, someone might owe $300,000, for example. Well, my philosophy is, and this is something I tell everyone, whatever field of medicine you want to go into, make sure that whatever you borrow, if you need to borrow to go to med school, is the amount equal to 1 year or less of the salary you're going to make that first year. So people who go into primary care, like I did, I thought I was going to be working in some area in Africa, maybe being paid next to nothing. So I put myself in a position where I wouldn't owe much. I went to an in-state school, I got scholarships. My husband is a radiologist. Radiology compensation is far greater than family medicine. So he was able to borrow quite a bit to go to an out-of-state school, which is what he did when I met him, to an out-of-state school, because his salary, his 1 year of salary was far more than the total amount he borrowed to go to med school. It seemed like a huge amount. However, when you look at compensation for different fields, it's really not that much, especially when you consider you have 20 to 30 years to pay it off if you want. So, that's another argument that a lot of people use. Oh, it just costs so much. It's so expensive. But again, there wouldn't be any doctors in this country if everybody was, saddled with so much debt that they couldn't live. The other is making sure the people around you have ambition, who understand your ambition, who understand your goals, because otherwise they'll start chipping away at yours. Again, people's insecurities will magnify your own. Everyone has insecurities, but the last thing you need is for other people around you to make yours worse. Another is to have hobbies. Don't make everything in your life about getting into med school, being in med school, becoming a doctor, being a doctor. You have to have some balance. There has to be something else that you enjoy, because as soon as something happens that may not be according to plan, you need something else psychologically to fall back on. For me, it's music. I love music. I play instruments. I like to sing. I also paint. And so those things have always been sort of wellness measures for myself all throughout. The other is to, if you're not healthy, get healthy. If you are healthy, stay healthy. You can't do anything well if your body shuts down. And stress is going to be there. So you have to mitigate it by, eating as well as you can, exercising regularly. It's a good mood stabilizer. It's a good empowerment tool. And so being healthy, especially if you're going into healthcare, makes a whole lot of sense. It also takes away the feeling of being a hypocrite. If you're unhealthy, how are you going to teach other people how to be healthy if you yourself aren't following your own advice? So that's my presentation. And if anyone has any questions, I'll be more than happy.
Thank you very much for that incredibly informative session, Dr. Toomer. If anyone has any questions, they can feel free to ask now, and we will now begin our Q&A session. My name is Minahil, and I'm an undergraduate student at the University of Maryland Honors College studying neurobiology and physiology. To start off our Q&A, by hypothetically inhibiting our lateral hypothalamus, which is responsible for giving us sensations of hunger, is this a possible route or treatment to weight loss?
Okay. Oh, I didn't realize you were asking me a question. I thought you were still, okay, can you repeat the question?
Of course. So by hypothetically inhibiting our lateral hypothalamus, which is responsible for giving us sensations of hunger, is this a possible route or treatment to weight loss?
Yes, it is. But then again, whatever medication that you used, you have to stay on that medication. So if it's based on okay, there's different ways of doing things. You can do things immediately with medication that suppress whatever the process is, and that works. However, when you stop that medication, then you just go right back to where you are. Then there's a slower place where you do certain things that will change the structure and function over time. Our body is a homeostatic regulatory system, and so when you stop stimulating or when you add stimulation, it changes the function and the size of whatever part of the brain is being affected. Over time, you can change that function, you can change that size, and but that takes a lot longer, and most people give up before they get to that point. That biofeedback mechanism gets disrupted. So yes, but long term, it takes a lot more than just focusing on one area of the brain or um, specifically. And again, weight loss is important, but again, it's not essential. It's more the health aspect and what happens with your weight as a result of that that's much, much more important. Because really it's not weight loss, it's fat loss is really what matters. Does that answer your question?
Yes, thank you.
I tried to keep it somewhat general just because I know that everyone's background is different. So
Thank you.
the other thing I just want to do before we get to the next question, do you mind if I share my screen again? I actually have a way for people to contact me on my last slide. So I can keep that up so that way people can, um, so that way, anyone can write down my information so that they can contact me. Because I really don't mind if people DM me with questions also if they don't get them answered today.
That's perfect. Thank you. That actually, I think you kind of alluded to it in the previous question, but what are your thoughts on prescription medications for weight loss and what are the side effects for these medications?
Okay. So there are different medications for weight loss. And those medications, some of them are very, very good. And I mean, they're like health game changers. Others are not. So I'm sure many people have heard of phentermine or Adipex. What that does is suppress appetite. When you suppress appetite, it works only if your weight gain is from overeating, which for many people it isn't. It's not how much they eat, it's what they're eating that causes them to gain weight, depending on their the underlying cause of weight gain. There are other medications that are now being approved by the FDA that work really, really well to help with, and really, again, it's not weight loss, it's fat loss. You can lose a lot of weight, but if that weight is also muscle, it's actually unhealthy. There are a lot of very unhealthy thin people walking around. There's also a lot of people who are overweight who are much healthier than those thin people walking around. So again, it's not about weight necessarily, but it's about fat. Fat in the body causes inflammation. And so that's really what the focus is, although no one uses the term fat loss, they just say weight loss. So using medications that will drop fat production, prevent fat production, and reverse fat production are wonderful, especially if they cause other things. Because when you use these, there's medications that are out there that started out as diabetes medications, but they found that it helped people lose weight as well. And so now they're being used just for weight loss. But the wonderful thing about those medications, they don't just cause weight loss, they actually protect the heart. They reduce fat production. And that's why they work so well and why they're safe and they're wonderful, because it's not really about weight. It's really about the health benefits that they provide. Um, Many of the side effects of those are if people take too much too quickly, they will get nausea. They will have for the better ones. There's others that are medications that really don't even treat weight, they treat depression. A lot of weight loss medications are not about weight, they're about treating the cause. So they're antidepressants, they are anti-diabetic, they are headache medications because they're stress medications to help mitigate stress. So there are very good medications out there. There are some that are dangerous. I would say Adipex is one of the most dangerous. There are others that prevent fat absorption, which works temporarily. But again, there are a lot of good nutrients we get from fats. And when you block the body from absorbing them, become malnourished. And so those are dangerous. And so it's really important to focus on the cause and not the result when choosing what medications to use and how effective they'll be and how safe they'll be.
Thank you. And just a follow-up question to that one, what percentage approximately on average are your patients receiving weight loss medications?
I do not prescribe medications for weight loss. I prescribe medications to treat the cause of the weight gain.
Mhm. Thank you.
So I would say most of my patients get medication, but it's not because I'm treating their weight. I look for the cause of their weight gain. And so what I'm treating often is pre-diabetes, insulin resistance, diabetes. I treat a lot of depression. I treat a lot of anxiety. I treat the emotional reasons that people might overeat. So if they're emotional eaters, I treat what's the emotional part. I don't treat the eating part. But then also in the process of that, I also give people tools on how to not have to use medications also. So when I lost my 75 pounds, first 60 and then another 15, I didn't use any medication at all to lose weight. All I did was get my diabetes under control. And so any medication I took was simply for diabetes. And eventually what happened, I could come off those medicines. Because really, and then the other is depending on where someone is and how many other diseases are related to their being overweight or obese. Gastric bypass surgery or some type of surgery is a real option, especially if someone is at a point where, their heart's about to give out, their kidneys are failing or something else, and you just have to do something really quickly and drastic. Anything that you can do to get them back into a healthy space is beneficial and worth trying.
Thank you. And what are your
You're
thoughts on the
welcome.
American Board of Obesity Medicine certification? And do you think it's necessary for physicians to have the certification?
No. Um, I think it makes their patients feel better. Well, doctors in general, we're very certified oriented. We like paper, we like pieces of paper to um, validate who we are. We're used to having letters, MD. We want other things behind our name to sort of validate. I am a member of the Obesity Medicine Association. I am not obesity medicine certified. And the reason is that it's not all about obesity. Not everyone who needs to lose fat is obese. And not everyone who is obese needs I find the American Obesity Medicine certification tends to focus a lot on medications rather than lifestyle changes. Um, what is happening a lot in medicine now is that people are getting certified as a means of supplementing their income rather than truly using their knowledge to better patient health. And I find that focusing on obesity doesn't necessarily help a person, um, doesn't help their health and wellness. It just simply helps their weight. And so often what happens is, again, they lose the weight, but it comes right back.
Got it. Thank you.
So, but that's my philosophy, because I don't, medicine is a last resort. Medication is a last resort for me in my use, because usually I can find other reasons why. Oh, thank you. Why other people would, because this is my philosophy in general. Whatever you do now, you should be able to do 30 years from now. Because if you can't do it 30 years from now, then whatever you're doing right now is going to all the benefits are going to reverse as soon as you have to stop doing it. So if you're on a medication you can't take when you're 80 or 90 years old, then whatever weight you've lost because of it is going to come back. If you can't exercise in the same way 30 years from now that you're doing now to lose weight, you're going to gain it right back. One of the beautiful things is that there are exercises you can do in 80. There's many 85, 90-year-old, weight trainers. Muscle is a wonderful tool to reverse so many ailments in the body. And you can do that at 90. But you can't take Adipex at 90 years old. It will make your heart stop. But you can take, Ozempic, which is a diabetes medicine, because it's safe and it helps your heart. So it just depends on the person and what their causes are.
Yeah, and speaking of diabetes, what can be the role of preventative medicine when treating diabetes?
The role of preventative medicine with treating diabetes is everything. When someone has a family history of diabetes, or they're at high risk of developing diabetes, and you get them to understand that early, you can prevent it completely without ever having to use medication, just simply by educating them and letting them know these are the things that you can do to make sure this never happens. Or these are the things that you're doing that if you keep doing them, you're going to end up a diabetic. And so, but it's so much easier to prevent something than it is to reverse it once you've got it. And so trying to explain to people that that's important and making it important to them, and then understanding why it's not important. When people say, well, I don't care if I get diabetes, I always ask why. And it has nothing to do with their health. It usually has to do with their self-esteem. So then you ask, why is your self-esteem low? Is it because you were treated badly growing up? Is it because you're depressed, and self-esteem and depression go hand in hand? Is it because someone told you you were worthless, or because you're in a relationship with someone who's putting you down, and so you never feel good enough about yourself to care if you're healthy or not? And so when you look at those things and you're like, okay, this is a psychological issue, this isn't a health issue. And so you start focusing on the psychology of that person and helping them reverse the psychology of whatever it is that's keeping them from wanting to be healthy. And so, again, that's why biopsychosocial approach is so important, because if it's because they're in a bad marriage or a bad relationship that's making them not care, is it because they're depressed? Is that why they don't care? Or is it simply truly because the biology may be causing those other things? Someone has a thyroid issue. Low thyroid can cause depression. It can make people irritable. So that means that they're depressed, they don't care, they're irritable, so it's affecting their marriage. And so all these things play into each other. So it's really important to always ask why and fix the why, and then the rest will fall into place.
Thank you, sorry, my mic was muted. Thank you, I really appreciate that. We're taking it from the root cause. We're not treating the symptoms, we're treating the root. So how do you take family history into account when given your specialty in family medicine for diseases such as CAD and diabetes? So for example, would you begin testing for a younger patient with such family history?
Absolutely. Absolutely. Especially one of the questions you ask when screening patients is, has anyone had a heart attack? A young person in your family had any heart attack or sudden death from heart issues? That can reveal a lot. And so family history is everything. It's always part of the workup, because then you know what to educate people on and what to tell them to look out for. what symptoms to look out for. And then also what happens if you help that person, that can actually trickle out into the rest of the family as well, because suddenly they know what to look for. So when they see it in their mother, or they see it in their father or aunt, uncle, cousin, they're like, oh wait, my doctor told me that if this happens, it's because of this. You should go get that checked. You know, so when you're educating an individual, you're not just talking to that one person, you're actually teaching the family. And so, or whoever else is around them who they have influence on. And so um, questioning someone's family history is extremely important, because almost everything is, again, it's either affected by them because of genetics or because of the social structure. If you ask somebody, is there a history of mental illness in your family? And they say yes, you know, my mother had severe depression. Well, you know automatically that depression affected that child growing up. So of course they're going to have some issues as an adult because of their interaction with the mother. If they have a suicidal parent and their whole life they're being, you know, they're worried that their parent, it may or may not live, that's going to create an anxiety that you have to address in order to prevent other things from happening for that person. But if you don't ask, you never know. And so family history, coronary artery disease, high cholesterol is genetic. So, you know, if someone has a parent who, grandparent, parent who had, you know, a heart attack before the age of 50, it is absolutely imperative you start checking their cholesterol very early.
Thank you. And now kind of switching over to medically underserved areas, what are some solutions to medically underserved areas? And are there shortages of healthcare providers?
Absolutely. There are shortages. They're not shortages, even in places where now there's shortages, because even if someone has really good insurance and they can afford to see a doctor anywhere, there are places of this country where there just simply aren't enough doctors. There are a couple of solutions. One is to increase the number of residency slots. If there are more places for people to get trained, there'll be more doctors to do the job. Is this push to use mid-level physician assistants and nurse practitioners, which help fill in the gaps for things that are routine. What medicine teaches us isn't just to teach the routine, but to recognize the unusual. And when you miss the unusual, bad things happen. And that takes years of training, years of education, years of exposure that physician assistants and nurse practitioners don't have. And it's of no fault of their own. I mean, it's just simply the number of years they've spent learning aren't the same. And so they are able to take care of the basic things. But when it comes to the more complex things, it becomes a case of not knowing what they don't know. And so, and that's for everybody. I mean, that's for all of us. You know, there's different levels of doctors that are, some are good, some are horrible. A really good physician assistant is still better than the worst doctor. So, you know, that it's all relative. But filling in the gaps of underserved areas is extremely important, because it does affect all of us economically. It affects all of us socially. This recent pandemic is a good, very good example of that. Everywhere we go now, every service we seek out is more difficult to get help. I'm sure you may have noticed that when you call a customer service, you wait longer, it takes longer to get help. The help you get isn't as good as it was before. And a lot of that is because the people who are most widely hit by the pandemic were those who were in the service industry. And those people generally often don't have access to good healthcare. And so they suffered the most during the pandemic. And so now we're suffering because the people that we relied on for different things aren't there to do the job anymore. And so, yes, access and underserved has more of an impact on us than I think a lot of people recognize.
Thank
Does
you.
that answer your question?
Yes, actually, and that actually went to that actually falls into our next question about social determinants of health. So, from your experience, what is the role of the social determinants of health when it comes to serving patient populations in underserved areas?
It's all everything. Um, it's one of the reasons why I say that I love the med school I went to, because the joke around Michigan was that Michigan State doesn't graduate doctors, they graduate social workers. I actually liked the idea of that, because what that meant was that we weren't just focusing on the biology of the person, we were focusing on their whole life. People who seek out help, all they know is that they're hurting, something's wrong, and they want help with it. But that hurting isn't always about pain in the body. It can be pain in their life, um, and or pain, pain in their life. And so when helping a person, you've got to address all their pain, not just part of their pain. You know, if someone has I'll give you an example. Someone comes in and says, "My knee hurts. It hurts all the time, but I work in a job where I'm on my feet all day. I can't work, my knee hurts. If I don't work, I can't make money. If I can't make money, I can't live. So what do I do?" And I say to the person, "Well, your knee hurts, but you're also very overweight, and that's straining your knees. So we need to focus on helping reduce the strain on your knees." So the immediate thing is, I can help you with pain. I can help stabilize your knee with a brace of some kind so that standing will be easier. But long term, if we've got to work on getting the work your knees are doing by reducing that work. And the person says, "Well, I can't, this is how I eat. And the reason I eat this way is because this is the only way I can afford to eat." So then the plan is, well, we have to figure out a way of improving your way of eating within your budget. And so then we'll do that. And then if we have to use medication that's covered by your type of coverage, we can also do that. And often that takes a little bit of advocating for the patient, calling up pharmaceutical companies, filling out paperwork so they can get medication for free for a year. And then looking at family, it's like, who does the cooking? Who does the grocery shopping? How many people are in the house? How old are they? Are they able to bring? So you have someone who's like, "But I do the grocery shopping. However, my spouse likes to do such and such, and they keep bringing junk in the house, and I can't resist eating it." So then it becomes, okay, do we talk to them both together and say, "Listen, this is what she needs, and you need to either support her or hide whatever it is you're doing." And so you have to take all these things into consideration. And so then it becomes, you're helping with their diet, you're helping with their marriage, you're helping with their finances, but they walked in because their knee was hurting. And that's essentially what a good family medicine physician does when they're able.
Thank you. And after screening depression in a loved one, how would one go about reporting it or referring them to a mental health professional for follow-up and treatment?
Depending on what it is, they don't need to follow. You just treat them. I mean, if I happen to have a strong background in mental illness, but most family physicians, if they pay attention and they really focus in their training, can actually treat most things. The only part that we have difficulty with is counseling, because usually counseling sessions are longer, and they require an hour, 30 minutes to an hour, which we just simply don't have the time to do. Most don't. So what you do is, in community health centers, often what they'll have is social workers, clinical social workers who are who provide counseling and life skill counseling, and if it's beyond their scope, then they will send to a psychologist or a psychiatrist. Um, but the early on in the diagnosis, often we can just treat it.
Got it.
And it makes a huge difference for people when they don't have to go to multiple places, particularly if they don't drive. if there's no one in your community that does that service, then they have no access anyway. So just you kind of by default have to be the person to treat them.
Thank you. And can the brain change from anxiety, and can genetics contribute to anxiety, depression, and other mental health disorders?
Absolutely. Many of the ways we react to things is our brain structure and our brain function. So how we react and the structure of our brain is directly related to the structure of our parents' brains. So then I'm sure you've heard of nurture versus nature. Part of it is nature, is genetic, is from what your parents did and who your parents are. And then there's nurture. Because of that brain structure, your parents, your people around you behave a certain way. And so that kind of contributes to the way you behave. There are ways of reversing it, but it takes someone to recognize it and to spend time helping someone reverse it, either through medication, through a combination of medication and counseling. Um, and so because when you think that, and when you think of, there's something also called epigenetics. If you're someone who's always under stress, your body organs are going to change. The way that they react to things are going to change. However, when you have a child, you pass on those characteristics, those traits to that child. And so it may take another generation to 2 generations to reverse that. Because again, you have to stay a certain way, then pass that on and make sure that those traits are not continued on. You have to break the cycle to your child, and then that gets broken so that child has a child, and they also have broken that cycle, so it doesn't come back. And so, but it takes recognition and focus, and again, consistency. Things don't happen overnight, and so they can't be fixed overnight.
Thank you. And switching to hospice care, our last set of questions. What is your favorite aspect of hospice care, or what was, and what did you find the most rewarding in having served hospice care patients?
The most rewarding I found were the families because they were always so appreciative. It's just very often in medicine, doctors get criticized a lot for things that are beyond our control. It comes with the territory, and so we're used to it. However, with hospice, it's all about comfort, providing emotional comfort, physical comfort, and so that level of providing comfort and having family members just that are appreciative it's wonderful. That's the most rewarding part of hospice care. And then just being able to help, like it's almost immediate. It's like someone's in pain and you have the tools to help them because you're allowed. I mean, there's so many things are regulated now. But with hospice, you're kind of given a free rein because everyone's like, the end of life. So, do whatever you have to help that person. And so that's a wonderful freedom to have as well. So that's the most rewarding part.
Thank you. And how would you personally define quality of life when determining whether it's worth saving a patient? And what are your thoughts on euthanasia and comfort life measures in the United States?
Okay. Quality of life is determined by the person themselves, not anyone else. Not something you can impose on someone. There are people who have had a leg amputated who feel like their life is over. You have other people who've had a leg amputated who's like, ooh, I'm going to get a prosthetic and I'm going to become a runner. Just depends on the person. So there's no way of determining quality of life for someone. They have to determine it for themselves. When it comes to worth living, again, it's up to the person. Everyone, as far as I'm concerned, is worth saving as long as they want to be saved. some things are futile. Like if someone's on a ventilator, they're brain dead, they have, they're not an organ transplant provider, then it becomes, what did that patient want before when they were able to speak and function? What were their advanced directives? What were their, which is why it's so important to have advanced directives to say now while you're able what you want to happen if you're ever in that situation, because no one has to guess. An example, my father passed away. He was 90, passed away last year. We knew exactly what he did and did not want to happen. So none of us had to guess. And so quality of life is determined by the person before they need it. That's the best way of answering that. When it comes to euthanasia, I personally could not and would not do it. And the reason is that if a person wants to die, they can do it themselves. Don't involve somebody else. But still, why do they want to die? Is it simply really because their quality of life is that bad? Or is it because they're depressed and it's being undertreated? Is it because, they think they're a burden to their family? So is it a perception issue? Their family would much rather have them, bedbound and able to talk to them daily and still get advice and still use, if their brain's functioning. And that person may say, okay, I want to go. And their families, because they think they're a burden to their family, but their family doesn't believe that. And so sometimes it's just simply a matter of perception. And then sometimes it's a matter of some other diagnosis driving that decision. And it's a matter still to know why. So again, quality of life is based on the person themselves, not anyone else, because everyone has biases. And so you can't rely on other people to determine what's good or bad, because their own prejudices, their own, biases, their own attitudes about people, places, things, gender, race, geography, religion. There's just too many variables that people pull into a decision to allow someone else to make that decision for you.
Thank you. And for our last two questions of our session, how do you manage your work-life balance?
I don't. No, I do. It's always a work in progress. Always. It takes planning. It takes determination. I'm in a very good situation in that I'm in a 2-doctor family, so my income isn't the primary income of my household. So it gives me some freedom to, to do certain things or not do other things. But then I went into medicine expecting to, my goal was to work enough to be able to finance all the other things I want to do, like travel, like have time to paint and do certain things. So if that meant working part-time, if that meant taking a job in a place where, I didn't have to, work every single day or all day. I was just not, I was willing not to make a certain amount of money just so that I could have the other part of my life I wanted. However, like I said, my husband's a radiologist, so he actually has the same sort of freedom without having to sacrifice income. But in family medicine, that's a little more difficult. And so what I do to maintain my work-life balance, or to have a balance, is one, the word no is a complete sentence. Learning how to advocate for yourself. When someone asks you to do something, not allowing other people to impose their expectations on me and my time. Well, I really need you to do such and such. No, you want me to do it. You don't need me to do it. And so, no, I'm not going to do it. And they'll try to make you as uncomfortable as possible. And you just stick to your guns. You're like, no, I mean, this is my time. This is my life. And you can't control it. And that's a good tool to have for all aspects of life, not just within medicine. Just being very much your own advocate and being very protective of your time. When I had children, the other thing though is that after I had my second daughter, I went into what's called peripartum cardiomyopathy, which basically I went into heart failure related to pregnancy. And I was told I had a 50% chance of living 5 years. That puts a lot of things into perspective. After that, it was very hard for anyone to convince me that I had to do anything, because I came too close to death for anyone to convince me that I had to do anything other than take care of my children and love them and to be here for my husband. And so a lot of it is perspective, really.
Thank you for sharing, Dr. Toomer. And for our last question, what is some advice you have for students who are currently or interested in pursuing family medicine residency versus internal medicine or med peds?
Okay. It really just depends on your passion. Family medicine allows you to basically niche your practice, niche your interest. If you want to be family medicine with a emphasis in gynecology, you can. You can do with an emphasis in obstetrics, you can. Sports medicine. Family medicine are basically in high demand everywhere in the world because you're trained in everything. Even if sometimes it's just a little bit of everything, you can always brush up or bulk up on other areas that you need to, depending on where you are in the world. If you end up in a part of the world where infectious disease is more of an issue, then you bulk up on that. But since you're also someone who has to deal with the social parts of things and the psychological parts of things, when someone says, we need a policy made, we need a policy, that's who they go to family medicine. I know many family medicines who don't see any patients. They're all in policy. Like I said, the Affordable Care Act was almost exclusively built off the intellectual property and the minds of family medicine physicians. They took a lot out that they shouldn't have, but primarily that's who they came to when they said, okay, we need a policy that is going to help give healthcare to as many people as possible. So family medicine is a good place for that. The only difference between internal medicine and family medicine, maternal medicine, you don't see pediatrics, you don't see obstetrics. And so if you're not interested in obstetrics, you're not interested in pediatrics, then internal medicine is a good way to go. And the other is, if you want to go into pediatrics, and med peds is a good way to go if you want to specialize afterwards. So family medicine, you can have emphasis, you can get fellowships and other things, but you're not considered quote unquote a specialist in that regard. You're still a family medicine specialist. But when you do internal medicine, you can become a cardiologist, a gastroenterologist, radiology is different in that you do 1 year of medicine and then 4 years of radiology. So internal medicine gives you far more options in terms of specialization. Family medicine gives you many, many more options in what you use your degree for, outside of medicine specifically. A lot of doors just open in a lot of ways, in a lot of places.
Thank you very much, Dr. Toomer. We truly appreciate you taking the time to answer our questions. This was a greatly informative learning session for all of us. I'd love everyone to please give a warm thank you to Dr. Toomer in the chat box for this incredibly informative session. Thank you so much.
I just realized I wasn't even looking in the chat for any questions. However, I do, like I said, I've done these a couple of times. And I always let everyone know you can DM me. I don't mind at all. I may not get back to you right away, sometimes because of algorithms. If you're not, a follower or Facebook friend or whatever, you might get lost in the um, I don't know, the space between me seeing it and not seeing it. But eventually I will, and if I find, I will answer. I don't mind at all. Don't hesitate. If I don't know the answer, I will find someone who will. Um, and so, or put you in touch with someone who can. Um, because I mean, we have to nourish our next generation of doctors. We are the only ones who can do that. And so, please ask me a question, if you have one, because I'd rather you get a answer. I'd rather you get an I don't know from me than a wrong answer from someone else who's never been through medicine.
Thank you. Now we're going to conduct our closing session with our quiz and future session dates.
Yeah, that's right.
The link to the quiz for the session is now live. Again, you'll need a 70% or higher to pass and receive certification. The link to the quiz is also going to be sent in the chat box. Many of our students have expressed interest in pursuing a leadership position in teleshadowing. We do have positions open on our leadership page, as we strongly believe in extending opportunities to others. Don't forget to join our mailing list if you haven't already, as we send session and quiz reminders right to your mailbox. You can join from the link in the chat now. It's also being sent in the chat. Now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. I'm looking forward to seeing you all at our next session, which is next Saturday on July 24th at 10 a.m. Eastern Standard Time with our physician who's mentoring us in emergency medicine. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing.